Welcome to the medical nursing unit. Topic 1: disorders of respiratory system. Pulmonary embolism. What is pulmonary embolism? The pulmonary embolism is defined as an occlusion of a portion of the pulmonary vascular bed by an embolus, which can be a thrombus or blood clot, tissue fragment, lipids, or air bubble. When we say pulmonary embolism, we understand an obstruction of one of arteries in the lungs. The most common emboli are thrombi dislodged from deep veins in the thigh. They can also originate in the pelvis, particularly in the pregnant women. You know how this happen. In some conditions, the blood clot can occur in the blood, especially in the deep vein of the legs or pelvis. Now, when that clot can move through the blood circulation until it reaches in the lungs. When it arrives in the lungs, it can obstruct the arteries. When it obstructs the arteries, means it will block the blood from the right ventricles to the lungs, or to the portion of the lungs. It will depend on the part of vessels affected. Because in the lungs there are smaller venules or the smaller capillaries. When you have a clot, for example, in the legs, can go through circulation until right ventricles, and right ventricles can pump and eject the blood with the clot to the pulmonary artery. And when it reaches those small capillaries, it can obstruct the capillaries and impede the blood to go to the lungs. Okay, I think pulmonary embolism is understandable. What are the risk factors for pulmonary embolism? The risk factors for pulmonary thromboembolism include conditions and disorders that promote blood clotting as a result of venous stasis, hypercoagulability, and injury to the endotracheal cells that lines the vessels. You know, in a normal function, when you breathe, you immediately clot because of the clotting factors. Now, when the endotracheal cells are injured and they bleed, the clotting may occur, and the smaller clot can circulate in the blood and cause such event in the lungs. Other conditions like stasis that you have to play a greater role to prevent it while you are caring a patient with retarded mobility. When the client is having a retarded mobility, for those who have paraplegia and obesity and whatever, they have a risk for stasis. They have the stasis of the blood. Now, with the stasis, maybe there should be any clot. When there is a clot, the clot can move from the stasis and go to the heart and reach the lungs and cause a pulmonary embolism. Okay, pathophysiology. The impact or effect of the embolus depends on the degree of pulmonary blood flow obstructions, the size of the affected vessels, the nature of the embolus, and the secondary effects. Pulmonary emboli can occur as any of the following: massive occlusion. The massive occlusion here, an embolus that occlude a major portion of the pulmonary circulation For example, the main pulmonary artery embolus, when we have an obstruction, an occlusion of the main pulmonary artery embolus, we will have a massive occlusion, as well as the main part of the lungs will not receive the blood. Embolus with infractions. An embolus that is large enough to cause infraction of a portion of a lung tissue. When we say infarction, this is a total absence of blood supply in that part. Multiple pulmonary emboli. This may be chronic or recurrent. If the embolus does not cause infraction, the clot is dissolved by the fibrinolytic system and the pulmonary function returned to normal. If pulmonary infection occurs, listening and scarring develop in the affected area of the lung. Yeah. When we say infection, we understand the causes of the part because the absence of blood supply. Yeah. Okay. What are the clinical manifestations of pulmonary embolism? Pulmonary embolism without infraction is the most common and the most difficult to evaluate. It will be characterized by sudden onset of dyspnea, tachypnea, tachycardia, unexplained anxiety, occasionally syncope, and pleural pain occurs. Sudden onset, it is sudden, it is immediate. Now, of dyspnea. The client was in normal, we were not having dyspnea, but suddenly developed dyspnea and tachypnea, and tachycardia and unexplained anxiety. Here, you will mostly think about the pulmonary embolism. For the emboli that causes infraction are manifested by pleural pain, dyspnea, pleural friction lab, pleural effusion, hemoptysis, fever, and leukostosis. If you have massive occlusion, that will cause profound shock, hypotension, tachypnea, tachycardia, severe pulmonary hypertension, and chest pain. Diagnosis: you can do blood gas analysis, chest CT scan, magnetic resonance imaging, what is MRI, magnetic resonance imaging, MRI. Treatment: they give anticoagulation is the successful treatment of pulmonary embolism that include heparin or warfarin and antivitamin. This is warfarin, this is antivitamin K. And let's continue with pleural disorder. We have seen that pleurisy or pleuritis is inflammation of the pleura, which become red and covered by an exudate of lymph, fibrin, and cellular elements. Manifestations: often preceded by upper respiratory infection, chills, fever, pain on inspiration, pleural pain, knife-cutting pain, auscultation, pleural friction rub over the affected area. You note that pleurisy is inflammation of the pleura. And the pleura, this is the membrane that covers the lungs. That will be the complication of the pleurisy. You have the pleural effusion. Treatment, we give antibiotics. What is the pleural effusion? The pleural effusion is the presence of fluid in the pleural space. It is abnormal collection of fluid in the pleural space resulting from excess fluid production or decreased absorption. Normally, in the pleural cavity, this is a space between visceral cavity, visceral pleura, and the parietal pleura. The cells of parietal pleura produce some fluid that will enable the lungs to expand without friction. but that fluids are eliminated through the lymphatic vessels. Then, when there is an imbalance between production and elimination, we will have accumulation of the fluid in that space that we call pleural effusion. Now, etiology. Pleural fluid accumulates when pleural fluid formation exceeds pleural fluid absorption. Normally, fluid enters the pleural space from the capillaries in the parietal pleura and is removed via the lymphatics situated in the parietal pleura. Fluid can also enter the pleural space from the interstitial space of the lung via the visceral pleura or from the peritoneal cavity via small holes in the diaphragm. Accordingly, a pleural effusion may develop when there is excess pleural fluid formation from the interstitial space of the lungs, the parietal pleura, or the peritoneal cavity, or when there is a decreased fluid removal by the lymphatic vessels. Occasionally, an abscess or other region is draining into the pleural space. Of course, when you have the in the complication of lung abscess, I've seen you can even have pleural effusion. When the abscess is drained into the pleural space, now there will be accumulation of those fluids. Pleural effusion is an indicator of underlying disease process that may be pulmonary or no pulmonary in origin and may be acute or chronic. Most pleural effusion are caused by congestive heart failure, pneumonia, malignancy, or pulmonary embolism. Types of effusion. We have transudate or hydrothorax. Source of accumulation. This is water fluid that diffuses out of capillaries beneath the pleura. This is when we say transudate, it is fluids, watery fluids. This may be caused by ventricular failure, cirrhosis, mechanical factors like lifting heavy object. We have exudate. The exudate, the source of this fluid, those are fluid rich in proteins, leukocyte, plasma protein, or kind that migrate out of the capillaries. Causes bacteria, pneumonia, tuberculosis, viral infection, bronchiectasis, malignancy, drugs such as nitrofurantoin, and also lung abscess can even cause it if one day it produce the pus. Empyema. Source of accumulation, collection of the pus in the pleural spaces, cause lung abscess, bacteria, and pneumonia. The effusion through bloody or hemothorax. This is hemorrhage into the pleural space, maybe the traumatic or injury. The child, donc chylothorax. The child, this is milky fluid containing lymph and fatty droplets that is dumped by lymphatic vessels into the pleural spaces instead of passing from the gastrointestinal tract. Now, this is maybe this is a milky fluid containing lymph and the fatty droplets. We called child. What are the manifestation of the child is pleural pain. If the pleura is inflamed, we have dyspnea, percussion, dryness, auscultation, pleural friction lamp. X-ray will show mediastinal shift. The complications of pleural effusions, we have compressed atelectasis, and diagnosis can have X or CT scan, pleural fluids examination, protein level to differentiate transudate from the exudate. Treatment: small collection of fluid normally can be drained away by the lymphatics. Thoracentesis is the needle aspiration in case of large pleural effusions. Thoracentesis, this is a medical procedure to drain the pleural effusion. treat the underlying causes, give antibiotics, and you can give an oxygen in case of shortness of breath. What do we call pneumothorax? The pneumothorax is the presence of the air or gas in the pleural spaces caused by a rupture in the visceral pleura or the parietal pleura and chest wall. We will have a primary spontaneous pneumothorax. What will happen? Due to rupture of apical pleural bulbs, small cystic spaces that lies within or immediately under the visceral pleura. Primary spontaneous pneumothorax occur almost exclusively in smokers. The initial recommended treatment for primary spontaneous pneumonia is simple aspiration. Now, this is the presence of the air in the pleural cavity. Primarily, it is the rupture of the pleural bulbs. Secondary pneumothorax, this is those due to lung conditions like chronic obstructive pulmonary disease and others. Pneumothorax in the patient with lung disease is more life-threatening than it is in normal individuals because of the lack of pulmonary reserve in these patients. Patients with secondary pneumothorax should be treated with tube thoracostomy. Traumatic pneumothorax can result from both penetrating and non-penetrating chest trauma. Traumatic pneumothorax should be treated with tube thoracostomy unless they are very small. If pneumothorax is present, means pneumothorax means there is blood and air in the pleural space. One chest tube should be placed in the superior part of the hemithorax to evacuate the air, and another should be placed in the inferior part of the hemithorax to remove the blood, as well as the air will shift upper and the blood will go in the base of the lungs. What do we call iatrogenic pneumothorax? Is a type of traumatic pneumothorax that is becoming more common. This is due to thoracentesis. We say thoracentesis, this is a needle drainage. We insert the needle into the pleural cavity and drain the fluids. So, in the procedure, we can have an error. The air can enter when we don't care very well the patient. So this is a traumatic pneumothorax due to thoracentesis and installation of central intravenous catheter. Most can be managed with supplement oxygen or aspiration, but if they are unsuccessful, a tube thoracostomy should be performed. Okay, yeah. This is the interior of the air flowing the procedure, medical procedure of thoracentesis. Opening pneumothorax. This is communicating pneumothorax. Air enter during inspiration and escape during expiration through the communicating chest wall. During a traumatic pneumothorax, we can have open pneumothorax. Here, open pneumothorax, the air will enter during inspiration and escape during expiration. We can have also tension pneumothorax. Pleural rupture permits air to enter during inspiration, but prevent its escape during expiration. Okay. The diagnosis is made by physical examination showing an enlarged hemithorax with no breath sound, hyperresonance to percussion, and shift of the mediastinum to the contralateral side. Tension pneumothorax must be treated as a medical emergent. The consequences of tension pneumothorax: compression atelectasis. Yeah, because the air does not escape, they will fill in the pleural spaces and compress the alveoli and the alveoli will be collapsed. Compression and displacement of heart and great vessels reduce cardiac output and death. Manifestation of tension in pneumothorax: severe hypoxemia, dyspnea, hypotension, percussion, or hyperresonance. The treatment. Immediate treatment is required in the case of tension in pneumothorax. Chest tube or a large bore needle is inserted into the pleural space through the second anterior intercostal space to decompress it until thoracostomy tube can be inserted. The chest tube is attached to a water-sealed drainage system with suction. After the pneumothorax is evacuated and the pleural ligature is healed, the chest tube is removed. Respiratory failure. Acute respiratory distress syndrome. Acute respiratory distress syndrome is a clinical syndrome of severe dyspnea of rapid onset, hypoxemia, and diffuse pulmonary infiltrate. What can be etiology of acute respiratory distress? Direct lung injury, pneumonia, aspiration for gastric content, pulmonary contusion, near drowning, toxic inhalation injury. Indirect lung injury: sepsis, severe trauma, multiple bone fracture, fair chest, head trauma, burn, multiple transfusions, drug overdose, pancreatitis, post-cardiopulmonary bypass. Clinical manifestation of respiratory distress syndrome: dyspnea, hypoxemia, metabolic acidosis, respiratory acidosis. Treatment: ventilation support, oxygen therapy, prevent lung collapse, long time for inspiration, short time for expiration. Corticoids or like prednisolone can be given. Thank you. Thank you very much. Merci beaucoup. Murakoze cyane. Mukomeze mutere inkunga iyi channel, mukanda kuri subscribe ndetse no kunzogera, kugira ngo ibindi bikurikira mujye mubibona uwo mwanya igihe tubishyizeho.